My name is Doral Fredericks, and I am the Global VP of Medical Affairs and Outcomes Research at Organon. Yeah, so I think that this is a really important question, and I think something it's great to delve down more deeply into. But I think, fundamentally for patients in pregnancy and postpartum, there's always been a little bit of a concern about obviously the possible adverse effects on the fetus or the newborn because of medications passing into sort of to breast milk. And so we typically garner information in those patient populations through things like patient registries and exposure data over time, right? So there's just a hesitancy, I think, to do clinical research in those populations specifically. But there's really more to it than that, right? And that is the complexity of hormonal changes in pregnancy, immediately postpartum, and around menopause are really fairly, I think, complex and heterogeneous, making them harder to standardize for research purposes. This is in contrast to something like acne or diseases that you see in puberty, which involve kind of predictable endocrine changes. So it's just one of those things that I think it's a harder patient population to study. And I think there's also another piece, which is that symptoms during pregnancy and menopause are often dismissed as being normal or an inevitable part of aging, and thus reduce maybe clinical urgency to investigate them. So again, this contrast with something like acne, which affects both sexes and represents maybe a larger potential treatable population, that's a little bit easier to study. And I think finally, maybe from a clinical perspective, when we think about it, many providers are well versed in normal physiological changes of pregnancy, but really lack the knowledge around maybe pregnancy-specific dermatoses. And so that'll contribute to a lot of mis and underdiagnosis. So I think you put all those things together and it just makes not only the medical research, but treatment of some of these patients just a lot more complex. It is one of those things, again, like I mentioned, it's really complex, but we know that these hormonal shifts fluctuate but continue throughout the lifespan. So when you're talking about menstrual cycles, pregnancy, postpartum, and menopause, those change at any given point. So let's just take estrogen for an example, because I think that is sort of at the baseline what everybody thinks about, right? In pregnancy, you obviously get these increases in estrogen levels, which shift immune responses, and this is well documented, right? It shifts immune responses towards a Th2 profile. And what that means is it can exacerbate certain dermatological conditions like atopic dermatitis. So you tend to see flares of atopic dermatitis during pregnancy, but because of that shift to the Th2 side, you might see a decrease in diseases that are caused by maybe a Th1 or Th17 side of the equation, like psoriasis. So you get maybe worsening in patients that have atopic dermatitis, but an improvement in psoriasis. Menopause, on the other hand, right, if you want to think about the completely other side of the spectrum, you have these sustained low estrogen cycles, which is associated with then increases in psoriasis for the exact opposite reasons that we just talked about, and maybe frequent or harder to control flares in psoriasis. Additionally, that low estrogen will impair skin function, the skin barrier function, lipids, and hydration. So you see a lot of older patients with dry skin, and that barrier breakdown and immune aging, just as part of the cycle of life, can unmask or worsen atopic dermatitis, especially on the hands, face, and flexural areas. But again, this is like one component in a really complex system, but things that are real and unique to women.